in Nashville. She's the director of perinatal services at St. Thomas Health. She's the co-director of the Comprehensive Perinatal Cardiac Clinic. She's at St. Thomas Health. She's a professor at the University of Tennessee. She's a clinical professor at Vanderbilt University. And she's an adjunct professor at Meharry Medical College. I always say I don't know anybody else that is affiliated with more universities and colleges than Dr. Graves. And on top of that, she serves on many state and national boards. She's widely published and is one of the national leaders for cardiac conditions in OB care. So it is indeed our honor to have Dr. Graves, and I'll turn it over to you.
Well, thanks, Brenda, for that introduction. And I'm really hoping that today we kind of are able to walk through cardiac physiology, kind of talk about why we're here, why we decided to do the project, and what our current state statistics are. So what we're going to really talk about today is we're going to discuss normal cardiovascular physiology in pregnancy. We're really going to be talking about implementing the screening tool that many of us know about and are really very helpful. That can be really very helpful. And at the end, I have some case studies to really kind of talk about what that screening tool can do. We're going to identify patients who are at risk and then prepare an algorithm to determine which patients should be admitted. And one of my most frequent questions that I get is what do we do when a patient screens positive? Next slide. So why are we even here? On this Valentine's Day, why are we talking about cardiovascular disease? And why has it become a major focus in obstetrics and gynecology? I will say for years, being a maternal fetal medicine specialist, a lot of our focus has been on fetal cardiac disease and fetal echo, and in my office, developing my sonographers and getting them certified. But in that, we also recognize that there's an issue as far as women are concerned when it comes to cardiovascular disease. Next slide. Now, uncontrolled or unrecognized cardiovascular disease in pregnancy has increased about to 25% over the last 10 years. It is it was respiratory diseases that accounted for our ICU admissions, but now cardiac disease accounts for 15% of our obstetric admissions, and it is responsible for 50% of our maternal deaths. And we know that many of these deaths can be prevented with early recognition. Next slide. Well, the good news is in 2023, the maternal mortality continues to fall. Much of our peak in 2021 had to do with COVID. And so this is really good news as far as maternal mortality. But we also know that COVID in itself, in women in particular, can cause complications of long-term cardiovascular disease, especially myocarditis. Next slide. These are the most recent statistics. We are still struggling with some differences in outcome. And one of the major differences is if you have to be older than 40, your risk is still higher than women who are younger than 25 and actually younger than 39. It seems that being 40 or older is that cutoff for poor pregnancy outcomes and mortality. Next slide. Mm-hmm. In addition, we know there are differences in outcome that are associated with other things such as race or where a person lives or what type of insurance the patient may have. So in this particular case, looking at by race, in other groups, maternal mortality fell, but in non-Hispanic Black women, maternal mortality continues to rise. Next slide. Now, what are the leading causes of death? And I've circled them here for you because people will say, okay, well, it's only 9% cardiomyopathy, and so it can't be that big of a deal. But if you look here, and I forgot to circle one, 7% hypertensive diseases, which is a cardiovascular disease, 9% cardiomyopathy, that's 16%, cardiac conditions, conditions, 13%, that's 29. And then if you add up thromboembolic disease, again, the 16, 29 plus 9%, that's almost 40% of our patients have some underlying cardiovascular condition that leads to maternal death. Next slide. Then also, we know that the timing of death is important. Most women die within 7 days, after 7 days to a year, it's 53%. Women who die on the day of delivery, 25% is mostly hemorrhage, or during delivery are hemorrhage. So our post-delivery deaths are often made up of cardiovascular disease. Well, what about Tennessee? Maternal mortality in Tennessee has gone down, which is great. But I want you to see that the middle of Tennessee, where Nashville has the best maternal mortality rate. Still not great because Tennessee is 39th out of 40th in maternal mortality of the 40 states that report. But West Tennessee has decreased slightly. East Tennessee has increased slightly. Much of that has to do due to mental health issues and substance use issues, which also can cause cardiovascular issues long term. Next slide. Now, these are the Tennessee pregnancy-related deaths, and this was in 2021, and you can see that we were at our all-time high of 64.9. Next slide. Now, luckily, in between 2020 and 2022, we've improved. In fact, our deaths have gone down 15%, with cardiovascular conditions second behind substance use disorders for those causes of death. Next slide. Again, pregnancy-related deaths. Most women do not die during the pregnancy, but after the end of pregnancy, and many of these women who are dying have cardiovascular conditions. Next slide. So, can we prevent cardiac deaths? If we say that this is what is happening, what do we do toward prevention? Next slide. So, this is some work that was done by the California Collaborative when they began to look at their deaths. And what they found is that between 2002 and 2006, there were contributing factors. Some of them had to do with provider-related issues. About 69% of the cases, there was delay in the clinical warning symptoms, and we're going to talk about why that is. There was ineffective or inappropriate treatment. As you know, often people are still nervous about treating pregnant and postpartum women. There was misdiagnosis because some of our diseases like preeclampsia actually aren't seen anywhere else but with us. And there was failure to refer or to consult often the cardiologist or obstetrician. So they felt that quality improvement opportunities was better recognition of signs and symptoms. This is kind of leading up to how we got where we are. Shortness of breath and fatigue, looking at tachycardia, blood pressure changes, and then improved management of hypertension. Next slide. Now, there's some patient-related factors as well. So about 70% of these contributed. There was a presence of an underlying medical condition, which may or may not have been sent out for management during pregnancy. Obesity in 31%, but in our population, that's probably more like 60%. Delays in seeking care because of again, a lot of our postpartum education prior focused on what happens to the baby and when you should bring the baby back, but not maybe when the mother should come back. And then the lack of recognition of patients. We didn't do a good job for cardiovascular symptoms. And so they felt like there were opportunities to educate and to look at these modifiable risk factors, such as discontinuing drug use, improving blood pressure control, things of that nature. Next slide. What they found is that 24% of all cardiovascular pregnancy deaths and 31% of cardiomyopathy deaths were potentially preventable. And how do we go about learning how to prevent these deaths? Next slide. Again, they also found that dilated cardiomyopathy was the most common cause of cardiovascular disease, and then their population comprised about 45% of this. Some of them were peripartum cardiomyopathy, and some of them were dilated cardiomyopathies. And one of the things that we're finding out is a lot of the cardiomyopathies that we see, even peripartum, have an underlying genetic component. So, as we learn more about cardiovascular disease in pregnancy, yes, they got cardiomyopathy from being pregnant, but why did they get it? And looking at those components. And the major risk factors for this were, in their population, lower socioeconomic status, substance use, hypertension and preeclampsia, obesity, and African American race also have increased cardiovascular risk factors as well. And in conclusion, they felt that the signs and symptoms of normal pregnancy could mimic cardiovascular disease, that most cardiovascular disease was not diagnosed until after the woman had given birth or died. And so there need to be an increased awareness for the potential of cardiovascular diagnosis, preconception counseling, and then referring these patients to a higher level of care. Next slide. Well, since it's Valentine's Day, and it's Women's Heart Month, I think it's only fitting that we should be looking at how the heart works out. And I put the heart, I love this picture of the heart of a treadmill, because pregnancy is a 294-day treadmill exercise for the patient's heart. I want you to think about that as we go looking at physiology. Next slide. So the first thing that happens is your heart has to mount an increase in cardiac output. This is 30 to 50%. So, when I was I trained in just regular adult ICU. So I was used to seeing cardiac outputs of 4 to 5. Back in the day when we put a Swan-Ganz catheter in almost everyone. Then I went on the OB floor, and I was there, and everybody had a cardiac output of 6 to 7, some of them. So 4 to 5, 6 to 7. Heart is already beginning to work hard. And for every, like a twin gestation, it's even more, 15%. If you have triplets, it's about 25%. I took care of a set of quadruplets who actually had cardiac heart problems after delivery. It is 30%. That's the amount of blood your heart has to put out in order to be able to perfuse the placentas. It peaks about 24 weeks gestation, so people who are going to get into trouble, it's around that time. And then when you're in labor and delivery, it increases another 30 to 40%. And this is important because this is one of the reasons that people use regional anesthesia and epidural, because the epidural can kind of decrease some of this because of the systemic, because it blocks a sympathetic response. And while we judge stuff on the uterus, the cardiac output in pregnancy doesn't return to normal to 3 to 6 months. I always tell my patients this because when they're looking for their blood pressure to get better or any of those other things, it's 3 to 6 months. Next slide. And if you look, you can see this is just some cardiovascular adaptations. You can see about 24 weeks it plateaus and stays there to 40 weeks. But, the cardiac output goes up again. And in the active phase of labor, it continues to go up. And then immediately postpartum, there's an autotransfusion that occurs, which actually increases cardiac output from 80%, and sometimes as high as 80% of their baseline level, which means that just because the baby's out doesn't mean the patient is not going to get into trouble with pulmonary edema and other issues. Next slide. Well, in response to your cardiac output, your systemic vascular resistance, which is how your vessels relax, begin to vasodilate. And this can be as early as 5 weeks gestation. This is why we often miss blood pressure issues in this time, because of the fact that by the time the patient gets in to see us, she's already kind of vasodilating and her blood pressure is down. It stops this natters about the middle of the second trimester. So it is about a 40% decrease above baseline, but it returns to pre-pregnancy levels early in the postpartum period. It begins actually to return to pre-pregnancy levels around 32 weeks gestation. And this is the whole reason that we see people every 2 weeks after 28 weeks. It's based on this physiologic principle that if your cardiac output is up and then your systemic vascular resistance begins to return to normal, this is the time you're going to become hypertensive. Next slide. And this is, you can see here, your cardiac output is as high as 6.2 in the second trimester. And then your systemic vascular resistance begins to rise in the third trimester and returns to normal, relative normal in the postpartum period. Next slide. Well, what about blood pressure? I just talked about cardiac output and blood pressure, and blood pressure is a function of those things. So blood pressure decreases as early as 6 to 8 weeks over their preconception values. And let me tell you, when people who have chronic hypertension, this decreases more than in people who don't have chronic hypertension. So therefore, again, this is why we may miss someone who really has underlying chronic hypertension. And I always tell people, if somebody's like 130 over 80 at like 12 weeks, they probably were 140 or 150 over 90 before they became pregnant. This blood pressure drops in the second trimester, corresponding with your systemic vascular resistance, and your diastolic and mean arterial pressures decrease more than your systolic blood pressure. And this is important because often people love to treat by mean arterial blood pressure in pregnancy. And what you need to know, it's always lower than when you're non-pregnant. And then it again begins to rise and returns to preconception levels in the postpartum period. Next slide. Here again is just this kind of schematic. You're going to see these serial blood pressures. You know, this is pre-pregnancy. This is early pregnancy, second trimester, which we see a lot of our patients. So you can see how we could definitely miss chronic hypertension if the patient presents in this second trimester. Next slide. Well, what about blood volume? Blood volume also increases 30 to 50%. Now, red cell volume only increases about 18%, and this is why patients who are pregnant appear to be functionally anemic. You get more plasma cell volume coming back. And then the blood volume slowly begins slowly in the first trimester and progresses to about 34 to 36 weeks. And some of the normalization of blood volume comes with delivery, but with blood loss. There's also an increase in coagulation factors. So as we talked about at the beginning, thromboembolic disease is increased in pregnancy as well. Next slide. I just wanted to show you, this is your total blood volume, this is your plasma volume, this is your red cell volume. This is important because all pregnant women will have a functional anemia. It's almost like nature is giving you crystalloid per se, like we do when someone's bleeding and trying to explain the blood volume. So basically, in a critical care setting, before you get blood, that's the reason for crystalloid, because we're trying to expand circulating volume. It's the same thing in pregnancy. Nature is trying to expand circulating volume without, but does not increase your red blood cell mass volume. Thereby, like I said, having issues with anemia is very common. Next slide. Now, there's also some other changes. Heart rate has to increase by 10 to 20 beats per minute. The overall change in heart rate is about 20 to 25% over baseline. This becomes an issue because a lot of women run in the 80s and 90s, especially if you're not conditioned. So if you increase your heartbeat by 15 to 10 to 20 beats per minute, that puts you in the tachycardic range, but it just may be normal for pregnancy. Keep in mind, like in multiple gestations, because you have more cardiac output, your heart rate may be even significantly more increased. Now, stroke volume also increases by 10% by 24 weeks gestation. Stroke volume and heart rate are also part of blood pressure control. And so therefore, understanding stroke volume and its relationship to blood pressure is important. And in fact, this is why labetalol often works, because it helps to reduce stroke volume, and that then reduces blood pressure. There's remodeling of your left and right ventricle, And you'll see this on echo with an increase in diastolic diameter and left ventricular mass. Next slide. Again, here is a kind of a schematic, and I'll be happy to share my slides of things that happen. There is no left ventricular longitudinal strain on echo in the first and second trimester. You can see it sometimes in the third trimester, but you see you have continued to have this increase in left ventricular mass and in diastolic volume. Of course, early postpartum, there's an increase in your systemic vascular resistance and your left ventricular longitudinal strain, which we often see when we have patients who come in with postpartum preeclampsia. Next slide. This is another schematic, and I just want to remind you about cardiac output going up 30% in labor, 50% in the second stage, 80%. And we can talk about managing these patients, but really paying attention to autotransfusion is important. When I have a patient with heart disease, I have them drop the legs of the bed so that some of that won't come back into the system as much. I often don't take out a uterus for a cesarean section to try to manage this as well. So paying attention in the cardiac patient to these physiologic changes is really important. Next slide. There's also some changes in your EKG. You can give a thumbs up how many people get an EKG on pregnant women, and it says anterior MI of unknown significance. And so then you're like, oh, does that mean something? Or does that mean nothing? It means nothing. What it means is that you have a shift in your QRS axis to the left and these Q waves in T with an inversion in 3 in AVF. If you weren't pregnant, that would mean that you had some type of anterior issue. There's also some minor ST to T wave changes. And patients, as you know, will have premature atrial contractions and PVCs during the pregnancy, often which are common and normal and don't require treatment. Next slide. Now, this is your echo. And so this is something that you probably, when you're having your cardiologist read, they may not know these things. So these are things for you to understand so that you can help out with and understand what your echo really means. Small pericardial effusions are not uncommon. There's multivalvular regurgitation at term, mitral, some tricuspid, sometimes pulmonary. You should never have aortic valve regurgitation in pregnancy. If you do, it is abnormal. Next slide. And with preeclampsia, this is from one of my good friends out of Hopkins, who is also a maternal fetal intensivist. He looked at preeclampsia and looked at echoes. The things we've already talked about, left ventricular wall thickness, but there's also right ventricular strain, which can lead to pulmonary edema. There can also be right atrial enlargement, which we often see on echo as well. Another part of echoes that I want to get people into reading is for looking for diastolic dysfunction. You will see this often in patients with long-term high blood pressure, and it tells you systolic function is great. Their EF is 65%, but they have grade 2 diastolic dysfunction, which means that they're going to have trouble handling their volume, especially when they're in labor and delivery and we're giving extra fluid and those things. Next slide. So, given the significant changes in the cardiovascular system, which people are going to get into trouble? People who can't change their cardiac output, those people who have like a pacemaker or severe stenotic lesions. Often you may have to, especially in people with pacemaker. And newly, I was at SMFM, and the critical care people, I would say, are the geeky of the geek. We stayed in our session later than everyone else, and we were discussing LVAD, which is using the artificial heart to manage a pregnancy. And so one of the things they talked about is since the LVAD has a fixed cardiac output, during the pregnancy, we would have to think about adjusting that. Because these are the changes that our cardiology colleagues may not be, sure of. People who are arrhythmia prone, we talked about the fact you have to increase your cardiac output and stroke volume. That causes turbulence around those valves. Anybody with an aortopathy, which is like a dilated aorta, or things of that nature because of the pressure of cardiac output and the stroke volume. And then, of course, anybody with pulmonary hypertension. Next slide. So let's think about this. Why is cardiovascular disease so difficult to diagnose in pregnancy? Next slide. The first thing is that a lot of normal pregnancy symptoms are what we see all the time. I'm tired. Tiredness in people who aren't, who are not pregnant could be considered cardiovascular disease. We normally say that's okay. Exertional dyspnea. I feel short of breath going upstairs. Okay. Palpitations. We just talked about that that the increase in cardiac output causes arrhythmias. Sometimes you can even get a third heart sound, and because of your increased cardiac output, there's elevated jugular venous pressure. This is how a cardiologist and how people who do intensive care, this is how we diagnose heart disease. They don't feel good, they have shortness of breath, and they have elevated jugular venous pressure. Well, in pregnancy, those things can be normal. But what's not normal? Severe shortness of breath. And I tell, if a patient says to me, hey, I had shortness of breath, and they come back and tell me the second time, I'm doing a cardiac workup. Even if they try to say it's not that big of a deal because it bothers them. Chest pain, if the patient has to lie on 2 pillows, if they have a continued cough, any type of abnormal heart rate like atrial flutter, fibrillation, SVT. It's not normal to be hypotensive. It is not normal to have tachycardia more than 15% above your normal heart rate. If you listen to a heart, you should never hear a fourth heart sound. And for those of us who listen to hearts, the third heart sound is Tennessee. That's the good one. Tennessee, 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 Tennessee. The fourth heart sound is the bad one, and that's Kentucky. Kentucky, Kentucky, Kentucky. If you remember that, Tennessee's good, Kentucky's not good. That can help you make a diagnosis. Then there's you may hear a murmur, and that's normal, but you should not be in pulmonary edema, and there should not be a pleural effusion. And pedal edema is quite normal. In fact, pedal edema is something I think that we make a lot of, but when it's 105 degrees in Tennessee, everyone has pedal edema. But what is not normal is to gain 10 pounds in a week. That should catch your attention. Those are cardiovascular symptoms. Next slide. So, how do we then differentiate? And this is where we came up with how do we figure out who we need to worry about and who we don't. So the first thing we did is we came up with the green, caution, and red. So who gets routine care? People with no symptoms, people with self-limiting symptoms, people who are only dizzy when they stand up or dehydrated, a heart rate that is less than 90 beats a minute, systolic blood pressure within range, and then everything mild edema. Who should get non-emergent treatment? People who have moderate issues with exertion, they need to be worked up. New onset asthma. I've diagnosed 2 people with heart disease who kept on wheezing, but they never had wheezing before. Persistent cough, or someone who has a sleep apnea. If they have chest pain, atypical, say my chest kind of hurts at this yesterday in the office. If they have brief episodes, but really no thought passing out, kind of vagal. But then the things to worry about, their heart rates in that 90 to 119 range. They have oxygen saturations that may be 95 to 97. Their respiratory rate may be elevated. These are things that we need to look at. And anybody who has these other things, you need to stop. If they're short of breath, if they have orthopnea, if they're extremely fatigued, if their blood pressure is greater than 160 systolic, or if they have occasional symptomatic low blood pressure, if they have a heart rate greater than 120, and if they have any other issues like SATs less than 95, except if they, desat from sleep apnea. All of those things are things we need to worry about. Next slide. So from that, we came up with a cardiovascular screening tool. This is the California Collaborative. What are the things we need to be worried about? We just went through them. Suggestive of heart failure, suggestive of arrhythmia, suggestive of coronary artery disease. If the patient has those symptoms, what about their vital signs? Resting heart rate greater than 110, systolic blood pressure greater than 40, respiration greater than 24, O2 sats less than 96. What are the risk factors? I reviewed those at the very beginning. Age, ethnicity, weight, pre-existing conditions such as diabetes and high blood pressure, substance use. Now, in our society, we have good and bad substances, but there are no good and bad substances. So nicotine and alcohol are on this list. And in fact, alcohol is one of the leading causes of drug-induced cardiomyopathy in women. Of course, opiates as well, if you have endocarditis. But opiates by themselves do not cause a drug-induced cardiomyopathy, but alcohol use will. And then, of course, the history of chemotherapy. We have a lot of women now who survive childhood cancer and breast cancer. Adriamycin in particular is cardiotoxic, and that needs to be evaluated. So then we add them up. There's one here, or one here. If you have one in each category, that's abnormal. If you have a combination of four of the others, is abnormal. If you have any of the abnormal findings, then they need to come and be admitted immediately. Otherwise, you can work them up as an outpatient. There's new data that says an echo and an EKG and a BNP in places where you cannot have an immediate echo may be helpful in ruling out a lot of cardiovascular disease, and I'll be happy to share that paper. And then, of course, event monitoring and full workup of the patient has decreased oxygenation and things of that nature. And if every results are negative, you can reassure the patient and return to routine care. Next slide. So these are the baseline assessments that we talked about. Don't forget to screen for substance use, and don't forget to screen for thyroid disease, TSH, in patients who present with arrhythmia. Next slide. When do you need further evaluation? If you have abnormal initial testing, you may need to refer to cardiology for stress testing. You may need to do event monitoring if the patient says that she has recurrent arrhythmias. And you need to consider the treatment of anemia and check for anemia in these patients. Some data suggests that you'll have EKG changes in tachycardia in 90% of patients. And I'm going to show you at the end some case studies that bear that out and will result in a borderline or positive screen. Next slide. Well, where do I evaluate the patient? Most of the time I evaluate them as an outpatient. Patient stable, they're chronic, they only occur if she exerts herself, and the patient is reliable and has resources to come back, and she doesn't have any of the equity issues that we often get into. And then inpatient evaluations for symptoms at rest, new changes. I often admit my patients after I've scheduled them several times, and I really need to get those the data because the patient's getting ready to deliver. Crackles, if you do an exam. A loud murmur, that should say loud murmur, sorry. And if the patient is unstable, acute onset, or has an abnormal troponin for when you're evaluating for chest pain, those patients need to stay inpatient. Next slide. So after you get the positive results, and you find some things, you need to really discuss things with the patient. What about, morbidity and mortality? How can I be safe? When should I deliver and where? And then there are some diseases such as hypertrophic cardiomyopathy, Marfan's, bicuspid valves that need the patient needs to be counseled about the risk to the fetus. And actually, there are going to be more because I just had one that was considered a pathologic variant, a genetic one, come back. Now it's considered a variant of unknown significance. It was now pathologic and the patient had a stillbirth. So we're going to see more of cardiac genetics come in as well. And then where to follow up post-delivery if they have a complication. Next slide. And of course, the positive screen doesn't mean that the patient has cardiovascular disease. So we maybe need to counsel them on the essential eights and opportunities for lifestyle change, such as weight management, stop smoking, dietary options, improve management of diabetes or chronic disease, and then kind of develop a roadmap for preventative encounters. We're going to talk about that on the 28th, but that's really important as well. Next slide. And if you look here, this is a paper that we published for the cardiovascular screening tool, and we we developed a schematic for Jack. Next slide. And you will see how to integrate your screening tool into your population. Obstetricians, primary care providers, ED, these symptoms, and then how to work them up, the referral pathways. And then there's a paper coming out that says there's also improved processes as far as being able to identify these patients and counsel them regarding our modifiable risk factors. And we know the screening tool improves our ability to detect, and that is statistically significant. Next slide. Well, let's talk a little bit about the importance of a multidisciplinary team. And this is really the concept that I really would like us to think about long-term. Preconception, counseling, risk assessment, medication safety, during pregnancy, management and monitoring, interdisciplinary collaborations as needed, imaging and things of that nature, labor and delivery, multidisciplinary plans, and don't forget anesthesia, and then cardiac optimization so that during labor and delivery, we're not struggling to figure out what to do. And then postpartum, thinking about lactation, looking at our cardiometabolic risk factors, contraception counseling, mental health screening, transition to care, and one of the other things that the patient has had a poor outcome, counseling regarding what needs to happen for the next pregnancy to prevent that outcome. Next slide. So in 2018, Dr. Davis and I wrote this, and I want us to think about this. We really are thinking about now changing what we do in pregnancy to be part of the woman's life cycle and not just an isolated event. And our goal is to really train our primary care providers and cardiologists who aren't trained, and I'm going to show you some data, in really taking care of this population. We're working on it. We now have education for both cardiology and MFM fellows. But if we develop teams and use the strength of each other and learn from each other, we can really reduce maternal morbidity and mortality. Next slide. And this is one of our challenges because we have these gaps. And this was from Natalie Bello, who she and I sat on the Preeclampsia Foundation. And this is 311 cardiologists. And they had their 51 teams. Most of them felt like they had gaps in medication safety, dilated aortic roots, chronic or acute coronary artery syndromes, which can sometimes occur in pregnancy with the transient thrombus, and valvular heart disease. Many of the respondents lacked access to cardio-obstetrics team, and only 29% of cardiologists received any training. Now, this is in 2002. So more than 1/3 of the fellows only saw 0 to 1 pregnant patients per year. So it is clear we just can't abdicate our responsibility of understanding our physiology to the cardiologist. And it's also clear that we have to be the first line in screening these patients to make sure that we're identifying patients who have issues. Next slide. So here are our take-home points. Cardiovascular screening can help identify patients that are missed through traditional care, and we know that it works. When a patient screens positive, education and counseling are important. Just don't say you screen positive, but you worked up negative, that's all great. But identifying these patients who are at risk, going back to that California collaborative data, 60%, can really reduce maternal morbidity and mortality. And since we know cardiovascular diseases is one of the leading causes of pregnancy-related mortality, we have to think about figuring out how we can improve these outcomes. Next slide. Now, as I close and get ready to take a few questions, I'm going to go through 2 case studies in cardiovascular screening. And these are from my institution, so I'm not going to tell on anybody else. Next slide. So this is the first one. The patient, 31-year-old, Bradley 1, obesity, chronic hypertension, has an MFM consult at 28 weeks. She has persistent shortness of breath. She screens 5 on the cardiac algorithm. Her risk factors are race, diabetes, obesity, chronic hypertension, and shortness of breath. That would be a 5. She was at increased risk. She underwent an echo. That was normal. Her lab tests were ordered, and she had a creatinine of 1.2 and severe anemia with a hemoglobin of 6.7, which translates to a hematocrit of a little bit less than 20. So she got a hematology consult and follow-up and required blood transfusion. She was admitted at 30 weeks for preterm labor and glycemic control, diagnosed with preeclampsia, which was probably due to some of her underlying cardiovascular risk factors, and delivered at 33 weeks gestation. Next slide. So what are the clinical implications? The patient had a workup that enabled the discovery of anemia of chronic disease. This has been associated with the increased risk of heart disease and cardiovascular disease, especially in patients with diabetes and chronic hypertension. And because we know correction of anemia improves pregnancy outcomes, this patient, we were able to support this patient initially, and then the patient subsequently had iron transfusions and some erythropoietin, which allowed us to improve her anemia profile, and thereby improved her cardiovascular profile and improved her delivery options. This patient did quite well in delivery and had no long-term sequelae. Next slide. Now, this is another one, and this we have a hard stop, but this is what happened. We had a 41-year-old Afro-Latina female who presented with elevated blood pressure. Her systolic was greater than 120. During the pregnancy, the patient reported intermittent dyspnea, however, was not evaluated at the time of initial presentation. She reported she had some issues lying flat while sleeping, but at the time appeared comfortable. Her clinical history was remarkable for chronic hypertension. Somehow, this patient, despite having these, was given a score of 0. And this is why screening correctly is important. Now, we can go back and score. She's of African descent. She has an elevated blood pressure. She has dyspnea. Sounds like she has orthopnea. And she has chronic hypertension. So, but no one knew this, so she underwent induction. After 15 hours, a cesarean section was performed. After delivery, the patient complained of shortness of breath and became hypoxic and bradycardic. She actually coded on the OR table, had appropriate resuscitation with restoration of circulation in 1 minute. At that time, we got an echo that demonstrated a reduced ejection fraction of 20%, with severe hypokinesis within dilated inferior vena cava and elevated pulmonary artery pressures. Now, one of the challenges of this case is that you can see that also in amniotic fluid embolism, but since we never worked her up at the beginning, we had no idea where we were, and it made it very frustrating. Her BNP was elevated as well, and a diagnosis of congestional heart failure was made. There were no studies for comparison. Next slide. So, again, if we had used the tool appropriate, she would have screened 5. We would have been able then to work up this patient prior, not in an echo, figured out where she was, and then this probably would not have happened. The patient did do well and had a favorable postpartum course, thankfully, and she had a repeat echo on postpartum day number 6, and she followed up with us in the postpartum preeclampsia clinic and with cardiology. And the long-term follow-up of this patient, her ejection fraction improved. And I often wonder this because she'd been hypertensive for a while, and we know that in preeclampsia, you can also get some changes on that left side that will eventually improve. But again, this is to illustrate what happens when what the tool can do, and what happens when we don't have the tool or we don't score the patient appropriately. Next slide. So these are some selected references. I'm hoping that there'll be some questions. I'm gonna finish up just a little bit early for those things. And I thank you for your attention, and I hope this is helpful and will actually, my charge is to get your tool implemented so that you can begin screening patients and doing the types of workups we need to do in order to improve outcomes for all of our population. I thank you for your attention.